Hello everyone, I am Vaishnavi Bhalekar of 1st MBBS from Bharati Vidyapeeth, deemed to be University, Medical College and Hospital, Sangli. I am here to present to you a case under the Dr. Sherlock Science of Deduction competition organized by Dr. P. H. Sain Medical Forum. Let us now look into the case. William is a 10-month-old boy who presents to his GP with swelling of the left side of his scrotum. His parents first noticed it about 2 weeks previously while he was in the bath. By the next morning, it seemed to have disappeared, but since then they have noticed it intermittently. It does not seem to be causing him any distress. Let us now look into the history of the boy as an approach to the case. He was born by caesarean section at 34 weeks of gestation due to poor intrauterine growth. His birth weight was 1.6 kg, which is quite less. Now let us see the past history. He had a swelling in the left side of the scrotum which first appeared for the first time 2 weeks ago. The family history is not quite significant in this case. Let us now examine the boy. On examination, it was seen that William is a healthy, active boy with normal weight, normal height and stable vitals. There seemed to be no pain, no swelling on the other side, no nausea or vomiting, no abdominal distension, and no pallor, icterus or clubbing of the nails. Let us now look into the local examination of the scrotum. On inspecting, there was no swelling at first. But then a swelling appeared in the left inguinal region as he started to struggle. The swelling had also distended into the left hemiscrotum. Both the testes were palpable in the scrotal sac. All other examination, including the systemic examination of the respiratory system and the cardiovascular system, were normal. The differential diagnoses are as follows: hydrocele, varicocele, ectopic testis, internal iliac artery aneurysm, saphenous varix, inguinal adenopathy, umbilical hernia, femoral hernia, inguinal hernia. It is not hydrocele or varicocele as there is no testicular pain on examination. There is no chance of ectopic testis as the testes were palpable in the scrotal sac. It is not internal iliac artery aneurysm as the swelling is not pulsatile. It is not saphenous varix as there are no signs of varicose vein in the lower limb. It is not adenopathy as the swelling disappears on gentle pressure. It is not umbilical hernia as there is no swelling in the umbilical region. It is not femoral hernia as the swelling is not extended up to the femoral triangle. Hence, we can say the 10-month-old boy William is diagnosed with indirect inguinal hernia, most likely due to patent processus vaginalis. Let us see the key features. Swelling on straining. The hernia was visualized only when the baby started to struggle. That is, increased abdominal pressure forced the intestine to bulge out into the hernial sac. Easy reducibility. With gentle pressure upwards, The hernial sac and its contents could be sent back into the abdominal cavity via the superficial inguinal ring. Abdominal USG, CT scan, and MRI are also useful in diagnosis of such a case. Let us now look into the management of the indirect inguinal hernia. Conservative management. The parents must look for any pain or redness around the swelling, as it could mean strangulation of the hernia and its contents. Herniotomy. Herniotomy is the surgery which is performed and recommended in children to repair the hernia. It is done under general anesthesia or spinal anesthesia. In case of William, we will do it under general anesthesia. In this procedure, we will reduce all the contents of the hernia and the hernial sac and ligate it. After the operation, one must watch for post-operative infections. The parents must also look for reoccurrence of the hernia in the next 3 to 5 years. Thank you everyone. I hope you liked the case presentation. I also thank all the organizers for giving me this opportunity.